Okay, let's start. Welcome, everybody. Let's wait a few minutes to see if more people join. We are streaming here on both on Teams. I advise everybody to join on the link of the event that you join directly on Teams. The connection is more stable and it's faster, but feel free as well to watch on LinkedIn. And thank you, everybody, for joining this afternoon. We at CW1 will be here presenting a series of webinars. This week we'll start with one theme that it's very spoken as of the moment, that it's the future of hospitals in the European Union. We'll have different approaches in different points of the European Union, and then of course we'll move over the coming weeks with other topics and see different perspectives of how the system is going to evolve and how the things are going to differ over the upcoming months and years until 2030, I would say. It's the limit date. Here we will have as well Dr. Maximilian. He's already here ready as well to start, and as well Managing Director of CW1 Germany. It's a very specialized neurosurgeon, but we'll just give a few more minutes to see who will come in, and then let's join and start the webinar all together and start this session with all of us. Max, since you're here, maybe you can say a few words to our audience. How do you feel for the first webinars of CW1? And finally, we are revealing a little bit more of what we are up to our new audience. So if you wanted to say a few words, feel free.
Thank you very much, Pedro, for the introduction. Yes, I'm very happy that I am invited to talk with you about the transformation and the future of hospitals in the European Union and give an insight about the work, what we have done, I have done in the past month. And yes, as an experienced neurosurgeon, I see in every day the lack of possibilities in the healthcare system, and I think this is a good point to talk about these days. What happened in the past and which consequences has it in the moment, and how we can optimize and try to repair these sometimes not the best decisions.
Yeah, it's going to be very interesting. We went quite deep over the thematics and the information. I remember that I sent you in the middle of the week almost 6 long studies with all data, and it was quite extensive. Okay, do we have people joining? Please, everyone, welcome. Feel free to join directly on Microsoft Teams. You will have access to the chat for questions and answers in case you are interested. And I think we will proceed and we will start. So let's talk a little bit, as I mentioned before, and for the new join. Welcome, everyone. We are here. Let's talk a little bit about the decades of transformation of what has been happening during the past 10 years and what has been happening mostly on the hospital sector and what it's about to happen over the upcoming years, because huge changes are coming. My name is Dr. Pedro Stark. I'm here with you. I'm the founder of CW1 and as well the current CEO for the whole group. Together with me, we have Dr. Maximilian, who will as well present a little bit about himself, but as a senior partner of CW1, is here to represent as well and give his insights, and is a very specialized doctor within neurosurgery, and hopefully he has better insights to give us exactly what happens in the OR departments and all the problems that live inside the hospitals. The agenda for this session will start with describing the overall picture of all the problems that are happening around the hospitals and around different points in Europe, because we are now 31 countries in the European Union, and each country has a problem, but there are problems that are transversal two different zones, and we bundled different zones. We grouped 4 different zones where we can distinguish common similar problems, and we'll be talking about them. We'll talk about what were the major problems in 2014, and not even the humanity thought that there would be a pandemic so soon, then what changed during the pandemic, and then we will advance to the major changes that are happening in 2024 and might happen up to 2030, since the European Union decided now to invest hardly in healthcare. For that, we'll base and do an analysis of what is the Nordic plans overall, what's the south of Europe happening, especially Portugal and Spain. It's a very, very interesting markets when it comes to healthcare because it's developing at a fast pace. Then we'll go into the German reality because German, with all the legislation and strong regulation, it's always a role model for all Europe. And then, of course, we'll talk a little bit about the whole objective of the EU and all the how it's going to change in the upcoming months. As I mentioned, together with me, I am Dr. Pedro Stark. I'm here representing CW1 and representing our vision for the future and a little bit about our work. My past, we all know, it's a little bit connected to different areas, but nowadays we are focusing purely on healthcare and showing innovation and bring innovation. Together with me, we have Dr. Maximilian, and I will ask you, Dr. Maximilian, to present a little bit about yourself to the audience so that they can see and hear a little bit about you. You have the word.
Thank you very much, Pedro, for the introduction. Hello, my name is Maximilian Bonk. I'm board-certified neurosurgeon, working at the moment at a huge hospital in Bavaria, and parallel, I'm one of the senior partners of CW1. In the last years, I've focused on my clinical work in the improvement of the neurosurgical techniques and the way how to perform surgeries to get more and more minimal invasive using modern technologies like augmented reality and also artificial intelligence and all these things. And these led that I'm more than a robotic neurosurgeon using the modern technology and the modern health devices to do surgeries. And this was one of the key points how I got in contact with CW1 to improve the whole healthcare landscape in Europe, because what is possible in a small sized room called operation theater is also possible to improve the whole healthcare landscape in Europe.
And I must say that since the moment you joined CW1, you were one of those new partners who really brought a change to CW1 and speed up the things. We are very glad that you joined us and that you are now part of the family. And it has been amazing travel that we had all together. As I usually call it travel since the moment we met. I really like you, and we keep pushing innovation forward towards our work. So no further ado, let's talk a little bit about what's the overall picture of the hospitals in Europe. And as I mentioned before, we need to mention the different happenings and the different zones that happened for the past decade and the changes that are coming up and making a huge innovation in the whole sector of European Union. So I would start to talk about the timeline of what happened for the past 10 years and what's going to happen over the years up to 2030. And we all know from 2014 to 2020, there was growth in healthcare, but there were too many changes. There were concepts still not being talked about, and the stability was quite slow, or was a stable period, but the growth was quite slow. The pandemic, with all the bad things that came, brought some good things as well, because especially on the year 2021, and I will show that so really soon, there was a huge change that required to input resources into healthcare. After 2023, when the pandemic is over, there was a change and there is a new thought around healthcare and the way to do things. And let's look at the public spending over healthcare. And as I was mentioning, if we look at the spending, until 2020, it was gradually increasing. Yes, it's quite a lot of money, and on the this side we have it as thousands of millions, which means it's 3 zeros more, but it has been very, very too much gradual spending up to 2020 when the first cases of COVID are announced in China. Suddenly there's a huge bump of inputting spending on healthcare, not only as a reaction or a prevention to possible cases in Europe, but was as well necessary to put resources in healthcare. You might wonder why from 2021 to 2022 there's a huge cut. Yes, there's less spending because there was a reduction overall on the resources allocated to healthcare. But good news, after 2022, and according to a report of McKinsey, healthcare spending is going to increase 6.5% every year, which is again good news, because if we arrive in 2030, we'll have the highest number ever on spending over the public healthcare. So let's look at the major problems in 2014, and it's very important that we look at what was going on during 2014. And first of all, let's look at Southeast Europe and all the problems that had during that time. And Southeast Europe, we are talking about the Balkan region plus Italy and Greece. And we had serious healthcare coverage gaps, which means not everybody had access or the same access to healthcare, combined with a rural dimension that people in cities or villages or zones that were remote and didn't have access so easy to a hospital, it was quite difficult for them to reach and have proper healthcare care. As well, Greece, especially Greece from 2004, had defaults, and there was still quite austerity measures and financial barriers to invest and innovate on healthcare. And of course, that brought other problems, like we start listening to the migration issue that Europe is currently facing, and the affordable healthcare was not so affordable in that region. On the other side, and I will let Maximilian present this part, because since as a natural German, he's more specialized to talk, but let's talk what was the reality of 2014 in Germany and in the Benelux area. Max, can you show us what was it?
For sure. Thank you very much. Yes, in 2014, there have been different problems in the whole Middle and Western Europe section. One of the biggest problems is the division between the outpatients and the inpatient healthcare providing, because due to more and more supplementary insurance, people got more and more better treated in hospitals, but this kind of healthcare level has not been delivered in the outpatient healthcare sector. That has been a big cleft between the outpatient and inpatient healthcare system. Additionally, due to the DRG system, there have been a shortage to the staffing, and more hospitals and other healthcare providers got into the private section, that these kind of hospitals and healthcare providers got more and more similar to companies and not similar to location where the people got aid. Then, due to the fact that we are all industrial countries, the level of governmental laws and regional regulation got higher and higher, that these kind of regulation got more and more complex, that the hospitals are faced with complex situation, not to get in conflict with the actual law. And in the end, mentioned previously, for the private sector, also the big hospitals and more the smaller hospitals got into a kind of company that they have to, in the end of the year, there has to be a revenue and got profit out of the healthcare of the people. So where on the one hand, financial problems, and on the other hand, law and governmental problems facing for the healthcare sector in the Middle and Western Europe.
Okay, perfect. Thank you, Max, for all that detailed picture. We see that Germany was as well quite complex at the time. Let's look at another case, which is the Nordics. And the Nordics is a special case because it has been always ahead of the time compared to the rest of Europe. It's quite innovative when it comes to technology in healthcare, and technology speaking, both Nordics and Baltic are a little bit up ahead. But they faced already problems that we are facing nowadays, and it's serious problems. The shortage of staff, it was quite accentuated already at the time in 2014 in the Nordics, that required immediate reforms. And since then, the Nordics countries and the Baltics have been trying to reform the workflows in order to deal with the shortage of staff. It's as well had another problems because of the shortage of staff and the pressure over the increasing of outpatients and inpatients. They had to start reform the normal workflow of a patient, and there were too much reduced inpatient times, and that led to sometimes people in fragile status to be released, and that led to other problems because they were not yet proper to be released, and conducted to other problems. Then together, and because of climatic reasons, led to, together with the aging population, led to a lot of increasing prevalence on chronic diseases. And that is a problem that it's still accentuated nowadays, but the Nordics are a special case that came with solutions to deal with this problem. Last but not the least, it's important to mention about the Iberian countries and Ireland, because it's another different reality from the whole rest of Europe. Like in Southeast Europe, with Greece and Italy, there was a problem of the rural access. People in the villages had problems to reach out to normal, proper healthcare in the big cities, and that was an increasing problem in 2014 that pushed governments to deal and perform some reforms. Like in the Nordics, there was already a shortage of nurses, and it's something that has been growing. And nowadays, in 2024, it's both nurses and doctors, but the first signs were starting to appear. It had long waiting lists to wait for an operation. I read a couple of studies for a normal knee joint fixture or some operation, on orthopedic operation. The waiting time was around 8 months, which was quite a lot. So of course, this was accentuated both Portugal and Spain. They were as well coming from the defaults in 2004, and they had huge economic constraints and gaps on their economies, which make difficult the life of the hospital administrators in how to manage and how to make the hospital work without having to look at all the time costs. And of course, there's one thing that, contrary to all the rest of the countries in Europe, the Nordics had already this, but not so talked as it was started to talk in the Iberian countries. There was started to exist different decentralization units, but since they were in the beginning, and I remember because I'm half Portuguese, and I remember in Portugal they started with the USFs and the ASES, and it was still very inefficient. They were not yet working properly, and they had to find a way to deal with the inefficiencies. And that was something that the governments had to look at and make a huge reform on it. So let's talk about the changes that in 2014 started to appear. And this is the point that we should look at because it's quite interesting. The first big change, it's the centralization. And what we mean with this. The centralization, it's when the hospital says, okay, we have outpatients and we have inpatients, and we will start rerouting the outpatients to other units, to different points of access to healthcare, so that they don't go all to the hospital and end up staying overnight, which then causes a risk on the bed management systems or different kind of situations. So Portugal and Sweden, for example, had already one case that was when they take away from the hospital and they start channeling the patients into the sjukvårdscentralen, which it's a complex word, but it's the Swedish term for a health unit. Like it's similar to, if we had to compare to Germany, it would be similar to an MVZ. In Portugal and Spain, it would be similar to a clinic or centro de saúde. And they start rerouting the patients, the outpatients, into these units in order for the outpatients to not go for the ERs. The ERs were even rebranded as acute, which, like the word in English, it means acute, and it's just for specific cases of outpatients that really need acute cases. If I had to clarify under the Manchester system, I would say that mostly red cases or yellow cases, but under yellow, the people should not go to the acute, otherwise they will face waiting times like 10 hours or 12 hours because they are not so acute. Anyway, the centralization in the Spain started becoming interesting because suddenly the government decides to divide the system in 17 different regions, and each region had their own autonomy to perform changes in the healthcare, and they started to have different ways of interacting and different ways of thinking in healthcare. Portugal was a little bit more ahead and decided to create the concept of the USF, which were the Centros de Familia, started having personalized care and starting having other functions to reduce the outpatients from the Centro de Saúde. And even the hospitals started to have different functions. And at the time comes the first concept, the ACEs, that make a little bit different, but more and more and more changes and more different changes starts to appear over the system. They qualified even, there were two models, there were the USF and the ULS Model A, and there was the USF and ULS Model B, and they tried with different approaches to improve the healthcare flows for the patients. Other concepts start showing up, especially the medical responsibility delegation, which means not everything needed to be done at the hospital. Other things could be done by other professionals, such as GPs, or we are talking about other professionals such as medical, the familiar, which is family doctor, GPs, maybe the laboratory technician, maybe the pharmaceutic, maybe the physiotherapist, maybe the psychologist. Medical responsibility starts being delegated, and we start going into a more centric approach for the patients. We start seeing other things, more quality assurance for care services, especially in Germany. And I think, Max, you can say a few words here, how the quality assurance within the German services started to increase. I don't know if you want to share a few words about this.
For sure. Thank you very much. Yes, the problem of the insurance got bigger and bigger in Germany due to the DRG effects and the shortage of staff, and how people got treated in the hospitals. That if you've got public insurance, you have got big issues that you get the 21st century medicine in comparison to the private insured people who got a big portfolio of different treatment possibilities and state-of-the-art possibilities, and also the full payback of the necessary medication and the most efficient medication, not that medication which got a discount contract by the public insurance.
Okay, perfect. Let's talk about other things that start to show up. And in Sweden, I like this one very much, because to deal with the shortage of staff, there were new schemes of compensation for the current professionals that were actually complaining that the pressure was becoming too much. And there were new financial models to deal with the shortage of staff, which the Nordics start to introduce, and they introduced very well, because it retained the current staff in order to deal with the shortage. Nowadays, it's a little bit more problematic, but it's still working. And the fact shows that the Nordic system still has a huge prevalence over public hospitals compared to private hospitals, because as it is, the physicians are still happy for being at the public hospital, although the pressure nowadays starts becoming higher and higher and higher. Another term that starts to become visible is the patient education. And it's not education saying, okay, go and check for these symptoms, but it's more education on the side of there are other ways of requiring for services. There are other ways of having more focus over your own health. There are more ways of looking at, be focused over your patient journey. How can you minimize or maximize your experience and be healthy faster? At some point, some other concepts like preventive medicine start being introduced, and this starts causing a change over the the current panorama, how the patient would feel his journey within the hospital. More things started coming in, more frequent auditing and anti frauds, because insurance companies, especially, we have Maximilian here, is the expert to tell us how the insurance companies pressure the current healthcare system of Germany, because of it's so complex that it works so in such a complex way that it becomes quite difficult sometimes to navigate through the whole bureaucracy. But across all Europe, more frequent auditing and anti-fraud controls starting happening, especially in the hospital world, because there were too many things not being audited, and more control in overall started to come in the overall systems. And then, of course, we start having more patient-centric approaches and more patient-responsible decision, which means the patient was in center, and more dialogue with the patient in order to maximize his own experience started to happen, and a new approach to healthcare started to become visible. Then, of course, we started looking at bigger problems when the pandemic comes. But first of all, let's look at what was happening in the south of Europe. Politically speaking, the government started to implement different things. And it's very important to look at this corner of Europe, let's call it like that, was having the really serious problems. And if we talk, we can see that there's a huge universal access problem to arrive to healthcare. And Greece was the first one in 2014 to make it law in order to make it uniform for all its citizens. But Italy and the Balkans still took a little bit time to change a little bit how it was working. As I was mentioning, the Balkans started to go into a huge change in order to modernize their healthcare systems, because there was bigger problems there. Italy, alongside with Greece, was already a little bit more ahead, and was doing some health reforms in order to uniform and starting to talk with the Mediterranean countries, which was quite nice. Portugal is not included in this study. I guess it's always the joke, Portugal, Mediterranean doesn't combine sometimes, but they were already talking in order to make more standard practices, which was good. But of course, they were facing huge challenges. Cost of healthcare was quite high. The out of the pocket costs, sometimes they were extremely high, and that made the challenge. There was an uneven distribution of healthcare resources across the countries, which means that people from, for example, I know the case of Greece, people from Thessaloniki or Athens didn't feel it so much, but people from Larissa didn't have the conditions that the people in Thessaloniki would have. People in the islands of Greece, and we all know the islands that are those paradisiac moments, they don't have so easy access to hospitals, which is another problem. And this put a challenge that the politicians at the time started to try to solve. And then, of course, there was a significant increase on self-reported unmet need for medical care due to the costs, the constraints, that the austerity effect was still there. But of course, there were other things coming, like the waiting times, the beds, the lack of beds. It started all showing from 2017 and onwards. If we look at the Nordics, there's already a huge difference. And if we try to say what's the biggest challenge here, I'm quite surprised if someone would imagine if not in the Nordics, because compared to all the rest of Europe, the biggest challenge started being actually on the reforms of the patient diseases, because cases of, for example, cancer patients started to become too high numbers, and they need to do a reform how the patient would feel the patient journey, and even deal with their long waiting times and deal how they would go through the system. Then, of course, we have this pushes more documentation over how the patient moves through the system, and there was a huge focus on all major cancer diagnoses, but other diseases, orthopedic diseases, other viral immunology diseases. All diseases start documenting from the moment the patient would come into the ER, what would happen and how would he move through the system, how many days would he have to be an inpatient until he's released from being a patient, and everything started to change. Then we have as well national standards becoming effective, which means all hospitals operating in the same way. There was no different care of treatment if it was in Karolinska, if it was in Sahlgrenska, in Gothenburg, or Karolinska in Stockholm. The same uniform standardized care is provided, and this became by law obligatory. Then, of course, we have as well mandatory structures, positions for care coordination, which means all professionals had to combine efforts, talk to each other, even across countries, started to happen. And then, of course, even, and I like this term, in Sweden, we have this term that it's multidisciplinary teams meetings, which means every professional started being together. Every professional started to talk. And we usually say in Sweden that we have a meeting of a meeting of a meeting, which means we sit a lot in meetings with different stakeholders and can have sometimes meetings with both doctors, physiotherapists, psychologists, nurses, all together to exchange ideas and talk how to improve the patient journey from the moment the patient comes in, how more comfortable can he be, how the quality of care can be improved, and all these subjects started being talked. In Denmark, we bring it comes as well one huge reform around 2016, if I'm not wrong, that was the freedom of choice, where all the patients could choose his own unit to be taken care of. And since there was already as well standardized care, it became easier for the patients to choose and move around the system. And then, of course, we see other things coming up with the shift of inpatient to outpatients to reduce the hospital beds per citizen. As of the moment, Sweden and the Nordic countries are the countries that have less beds per citizen, and yet the problem of shortage of beds are not yet being talked. We have actually a study we were talking in Portugal the other day with one of our studies that we did for the bed management systems and how to pre-book the beds and these kind of systems, and that this was a common practice in the Nordics, and in Portugal doesn't exist yet. It was quite a shock, but in the Nordics it's quite common practice. For example, if a pregnant lady after the first ultrasound can already know which hospital and which week she should be ready to be in labor, and when the time comes the bed is waiting for her, in order to not happen so much problem of shortage of bed. These are common practices. Of course, this, for our German friends in this call, it's a panic, but in Sweden we have the centralized control. Actually, across all Scandinavia and Nordic countries, there's one unique system where the records are exchanged, and the doctors can have access immediately to everything that happened to the patients, and this has been immediately increased after the pandemic, even more, to be more effective in order to detect possible things. And I know that Karolinska is using it to actually predict and diagnose diseases in early times. It's quite an advance in technology. Then, of course, we have the Swedish mentality of long-term planning. All the 5 countries, including Iceland and even the Faroe Islands, they have a huge planning up already to 2050, which means they know what's going to happen in the next 10, 20, 30 years from now on. They have already things planned to come up, and already a very, very strong plan and budget allocated in order to increase the innovation that's happening in the Nordic countries. No further ado, I will pass my words to my colleague Maximilian, which will be the best person to talk about Germany in 2014 and what's going on there. Max, please be my guest.
Thank you very much. Yes, in 2014, in Germany, there's been a financial structure reform, with the first thing that the reduction of the contribution rate, and it should be a relief to the insured person. In the second step, the government chose that the employees rate is fixed at 7.3% and should be a decoupling of the health costs from the non-wage labor costs. Then there has been an introduction of an income-related additional contribution to the public insurance, and it should aim to encourage more efficient administrative process. In comparison to that, the previous lump sum additional contribution has abolished by the working group between the Social Party of Germany and the ruling party, the CDU-CSU. It's the next point, I think. Yes.
Sorry.
Yes. And then there was the big idea to introduce an independent scientific institute, which should be an observer to secure the quality and transparency in the healthcare system, especially in the big metropole areas. And this institute has to provide precision information about faults and inefficiency within the healthcare system. Until now, there has not been a very good way to establish this. In the end, the major hospital reform was announced in 2023, but the idea for this big hospital reform can be tracked in the early 2000 times, and the key issues were the most criticized thing in the healthcare system, the DRG system, which has been the reason for over and under treatment of the patient. On the one hand, people got more and more surgeries because they got a bigger reimbursement by the insurance, or some of the treatments or diagnostic has not been done by the patients due to the fact there was no reimbursement to that. So this has been in the last decade the most controversial thing in the German healthcare system. And in the last years, due to COVID and many other things, there has been financial issues especially in the smaller hospitals, facing of the risk of closure and insolvency. And in the last years, especially last year, Professor Lauterbach introduced the plans to increase the amount of patients in the big hospitals, to close the smaller hospitals and establish the department of medicine, that there's no specific clinic for cardiology and vascular surgery, for example, and heart and thoracic surgery. It's called the Department of Cardiology, where these special clinics are summed up in one big department in university hospitals or supramaximal healthcare providers. And one other thing was the universal coverage, that since 2009, the healthcare insurance has to be mandatory for all citizens. And when you look at the statistics from the German Institute for Statistics, in 2014, nearly 85% of all Germans are covered by the public insured system. So that only a small amount of the people in Germany are covered by the private insurance. And this was in the last decade of 10 years, facing in, especially in Germany, the healthcare problems and the ideas to solve it. Now I would pass the word back to you, Pedro, that you can talk about the Hispanic Peninsula and Portugal, where you are the real expert for that.
Yeah, let's talk a little bit about what happened in Portugal and Spain, because it's two different realities. Let's start with Portugal, because Portugal, it's a very interesting case since 2014, actually since 2008, when the current government in 2008 introduces the concepts of the USEFs and ULES that were delegating part of the care that was provided in the hospitals to the USEFs, Centros de Saúde. They are called in Portuguese for our Portuguese listeners that we have in this call. But of course, this was an experimental concept at the time. And this was the idea of saying that in the different points of the country, there would be health center clusters, combinations of healthcares of ULES and USEFs. So ULES, we can the most closely compared to an hospital. And there were some points, even the idea that nowadays I'm quite happy that it works already, but a doctor from internal medicine could suddenly jump into a USEF and act as a family doctor and return to the hospital back and forward, not having one different contracts and different states of remuneration, one single state of remuneration, and thus dealing with problems like shortage of doctors. But this was still in 2014 a very experimental case, even though that government divided the different localities in Portugal and divided it in different groups, Group A and Group B, and tried to experiment different possible things to see how it would improve. Actually, the reforms in clinical governance started really being too much reformed in that area in Portugal and really bring up to speed how the workflows in the hospital would work in order to improve the hospital flows. Although it's very difficult in the country since part of the hospitals, they have huge passive huge debt associated. The government needs every year to inject public in the healthcare system, but it started already changing. And today, nowadays in 2024, with these systems, I'm happy to announce that they are working already in a better way than it was, and tends to be even more innovative in the space of 5 years from now on. But there's a huge problem convincing the old doctors to change it, but it's something that it's coming up to speed. On the other side, Spain in 2012 really changed a little bit the way they were thinking, and suddenly they decided to divide the national healthcare system in 17 parts across the 17 different regions with different legislations each region, which was quite an innovative step for Spain. This as well attached because Spain was already facing this issue in 2017 and 2014. They started to reduce, unfortunately, the healthcare coverage for undocumented immigrants because of the austerity measures that were in place, but trying to improve other areas because of that shortage. They tried to introduce, for example, the co-payments for medications, including for pensioners who couldn't have access to it, but there was always the austerity problem, and some things were started to be paying, especially on medication, that there were vaccines and medicaments that were offered for free before. Now they started to be paid, but that really pushed the system into different change and different improvement. Following the healthcare crisis in 2008 in Spain, that happens, more public spending shifts differently, and there's a huge change to the point of the big groups, and we are talking, for example, Rivera Salud or Quirón group that started to appear and started to expand. Nowadays, Rivera and Quirón are the two major groups in Spain and dominate quite a lot the way public healthcare, the way healthcare works. Not public, they are private, but they also establish public or private partnerships with the government in order to provide and give care to patients who actually need it as well, and a little bit in similarity to the German model. And there's a huge shift over the past 10 years on efficiency. Things work better, things work more efficient nowadays. There's a huge improvement on that part. And like in the Nordics said it already in 2014, but Spain was the first country in the middle of Europe to say, yes, let's try to create the health records so that we can communicate across different units, not only between hospitals and other units, other providers, but they started investigating the way to implement it. And this brought quite a lot of change over the healthcare system of Spain. But it's important to talk now what happened now? We are in 2024, and there are major shifts and changes in the ecosystem, in the system of Europe. And we are talking now on the European level. I think to introduce what's going on, it's actually to say, yes, we are thinking as Europe nowadays. We are not thinking as anymore as Portugal or as Spain or as Germany, although there's still a little bit mentality on this, but the concept like European practices and European standards is being pushed forward, and it's being started to talk. I read a couple of weeks ago the European Union wants even to push the unified healthcare healthcare record for the patient, which is the EHR. If they want to push a unified record across all the Europe, which means patients from Sweden can move to Germany and can move to Portugal and still have access to the same notes. This is a major change that the European Union wants to be implemented in 2026, and hopefully they will be there. But let's see what happens. Let's talk a little bit about the changes. But it's important to divide the changes because there's exactly two thoughts. There is the thought of pre-pandemic and there is the thought of post-pandemic, because as we mentioned in the beginning of this webinar, the pandemic really pushed the way we think healthcare and the way things work. And there's now a big difference over the way we think. And the pre-pandemic, we had already in the beginning of 2020, countries talking about the centralization. Yes, let's divide healthcare. Let's solve the problem of outpatients staying overnight, and let's move the outpatient problem into other units or other care providers in order to reduce the stress that the hospitals were facing. And there was even more ideas of how to solve the people that don't have access to hospitals so easy, people that live sometimes 100 kilometers away from the hospital. How do we solve this issue? And different measures were already being thought. One good thing that started being really well thought, and nowadays it's of the most importance because of AI, was the data compliance. And there was already major change and major awareness over data compliance. I'm quite happy that since the 1st of July, now in Germany, everyone who touches cloud data needs to have the C5 certification that really protects the way data is protected. And I'm quite happy that was introduced in Germany, and other countries are actually introducing as well. Sweden, Norway, and Denmark, they were always quite secure on that. But even countries like Portugal, I noticed by my parents that they say when they tried a little bit some of the solutions that were presented to them, more electronic and digital solutions, their first concern was, is my data secure? I know that the national app, the SNS 24, that keeps all the healthcare record and allows patients to book services. This app is from the Portuguese government. The first thing that when they asked, hey, can you help us use the app, there was like, is our data secured? And this, we are talking about people with 60, 70 years old that already are aware of their data. It's a huge change for a country like Portugal because it was not so common for that to happen. Anyway, another thing that was about to happen in 2020, and that's why we see in the beginning that huge bump during 2020, the EU was already shifting its focus to increase the spending on healthcare. And that was already causing some impact to even talk, can we have the standardized practices across every country in the European Union, which means every hospital working in the same way? That would be a huge shift. Possibly it will happen, but not yet implemented. And then, of course, there was already the problem saying, how do we solve staffing? 2020, there was already lack of doctors, shortage of doctors in both public and private, and both doctors, physicians, and nurses, and other medical staff. And there was already focus on creating incentives to keep the talent in the public sector, to not let it go to private sector, and to actually motivate them to contribute for the society. Of course, the pandemic changed everything and brought even more changes because we understood that the public systems were not working in the proper way. So, of course, the decentralization was accelerated. Now, the whole European Union is pushing incentives in different countries to push the centralization. Even Germany, my colleague Maximilian already talked a little bit of the changes of Professor Lauterbach how the hospital reform is actually changing this. But other countries are pushing as well more and more and more decentralization to diminish the outpatients flow from the hospitals, ERs. Then, of course, we have a push in data compliance, especially with in 2023 when OpenAI comes and releases the AI data. Nowadays, it's really fully understood the power that it has, and the data compliance that every hospital needs to go through. It's quite intensive, and it will become even more intensive due to the war in Ukraine and the attacks, cyber attacks that has been happening in all Europe. They will push more measures in order to improve the data compliance of every hospital and every healthcare system across all the bloc of the European Union. Budgeting, it's increasing, and due to economic constraints such as Germany and Portugal, they are really obliged to push a new hospital reform. I was talking last week, 2 weeks ago, with a hospital administrator in Germany, and she was saying that she doesn't know how the hospital will survive in 5 years, but she's eager to change the way the hospital flows work within the hospital in order to increase the liquidity of the hospital and perform innovations. And there are different reforms that are needed in order to really to reduce costs within the hospital, because hospital it's always a lot of costs coming. I know that, for example, we need, and now that we talk a lot about sustainability, we need to find ways of, for example, how to reduce the costs with the disposal of medical waste. That's very important to look at and find out a way to reduce these and improve actually the flow while obeying to sustainability, which is a concept that the Nordics are introducing already in their system, but I will talk further ahead over that. There's an awareness that we are having a crisis on medical personnel, and there's a huge shortage of medical staff, and there are huge problems that we have companies really providing medical staff non-stop. It's a huge demand on that market as of the moment, and we need to find a way to solve this. The European Union needs to talk about it and needs to solve it, especially because the privatization of hospitals is increasing. There are more and more and more private hospitals across all Europe, and don't get me wrong, private hospitals, it's not a bad thing, but needs to talk more to the public, because there's no need to have countries that say that they cannot exchange medical records between the private and the public because they have both problems on data compliance or the systems. They just don't talk to each other, which is the same patient, and the data is from the patient. The patient should be able to move between both systems without having to request in each system for his own data in order to deliver in the other hospital. And that it's a problem that needs to be solved. Both private and public should talk to each other more and actually exchange the data more often in a compliant way, of course. But let's look into specific cases, because it's quite interesting how it's going to happen. Before that, I just want to give a quick economic performance over to overall hospitals in Europe. And we can see that they are denominated by color. The Nordics, a little bit quite surprising, in Netherlands and Belgium, they are quite strong systems. The hospitals are not yet having so many hospital constraints when it comes to budgeting. But then we have already countries like France and Sweden that start having problems. 2 weeks ago, there was a manifestation in Sweden that professionals are saying, yes, needs to invest more in healthcare. It's a necessary risk because we need more planning, we need more investment. Germany, Professor Lauterbach is pushing lots of changes, and I believe that Max will talk about this, but it needs way more investment in healthcare, because we still have situations where people communicate over fax, and that is something it's not so common when said between other countries and needs to change. Then, of course, we have countries like Portugal and Spain and the Balkans, Italy as well, and even Greece, that they still suffer a bit problems of the austerity of 2004, and they are still feeling constraints in their healthcare systems. Curiously, on the Mediterranean, Portugal is the one that has less debt per hospital, but it's a common problem across the whole Mediterranean countries that needs to be fixed. And I believe one of the priorities of the EU is actually to invest more on the healthcare systems of the south of Europe, since all the Nordics and Germanic citizens like to spend vacation on the Mediterranean. It's quite a common trend in the past years to have vacation in the Greek islands or in the Spain coast or in the south of France or even in the Portugal. And this needs to be improved in order to have a standardized care all across the bloc. But let's go into more specific things and let's talk about the so-called Nordic plan in until 2030, that it's quite a change, an upcoming change across all the things work in Scandinavia. And if I had a word to describe how the whole thing is going to work, I would describe it as a systemized and sustainable and digitally enhanced healthcare innovation, because they are mixing multiple, especially five factors in order to improve and boost how the healthcare system works and how it's going to be improved in the upcoming years. So, of course, we have one thing that I know for Maximilian, that in Germany, for Germany, it's a panic when we say cross-border collaboration and send healthcare records across Germany. It's a panic in Germany because of the so strong GDPR policies. But yes, the Nordics are already planning that, and they are having more and more and more alliances and collaborations in order to facilitate all Nordic citizens to go across the different countries and have one single healthcare record, or at least access to the whole history of the patient, so that it can be better diagnosed and better treated for. We have really structural reforms. Things are changing. Things, how they work in the hospital, all the workflows within the hospital are changing quite a lot in order to influence the management and actually improve the way the care is provided to all citizens that live in the Nordic countries. And this is a big, big change that is coming and changing and being implemented so that it stays ahead. When we compare the different countries and systems, the Nordics stays ahead as a system of reference for others. We have a huge digital acceleration. I remember already when in 2020 I used to go to Germany, and when I said that I could approve and see the record all in the phone, that was something like, how could I approve GDPR consents on my phone? It was a huge shock in Germany. That existed already in Sweden and Nordic countries, especially Norway and Denmark, since 2010. It's been already quite implemented. Nowadays, they are already talking even more because of the war and all the measures around security that were implemented. They are already discussing new systems. How can we combine even MFAs and different techniques in order to are more digital and less intrusive to the patients, and still way secure practice in order to push forward innovation. Of course, when it comes to other medical innovation, especially in medtechs in Uppsala, there's a huge push how things are developing. And I have a couple of friends that they drive their own medtechs, and they have quite innovative medical labs, to the point the other day I faced a friend of mine that said he can measure the overall health of the patient just by the skin tone and the skin luminosity. That was quite an innovative step to discover, and was quite cool. And it's really pushing, especially the AI brought a change, although AI is very constrained the way it's applied to healthcare, but it's being explored in order to improve the patient mobility, how the patient moves within the system. Then, of course, we have one thing that might be really pioneer, or it might influence all other countries in Europe, that it's the sustainable practices within hospitals. Currently, there is a huge concern now with the ESG reporting. Hospitals in Sweden are now obliged to do ESG reporting, which is quite difficult to do, but really brings change to the work environment and brings more healthier practices, more sustainable practices, and actually helps reducing the shortage of professionals, which is a growing and common problem all around Europe. And the Nordics are trying to solve this in a different way, even introducing sustainable practices. And then, of course, when everybody looks at the Nordics, probably some of you know the Swedish fika or the Swedish after work, or the Danish concept of fika, that just take it calm after 4 p.m. It's quite stressed concerns, and this is one new practice and one new concern because of the stress that the hospitals are having. The stress management systems, it's something that is being really discussed in the Nordic systems in order to not overload the professionals, in order to actually reduce the pressure and the burnout rates that is being faced in the hospitals. And this is something that they really look at and really are concerned with it. When we look, and let's fly to another region, and this is a completely different region, the south of Europe, and what's going to happen there, and is already happening actually. We need to focus in different aspects when it comes to the consequences of all the innovation that was brought in 2014. So let's talk about the major innovation by then, which was decentralization. And Portugal kept pursuing the reform of the USCFs and the ULS to solve the issue of access to healthcare in rural areas while diminishing the outpatients from hospitals. But there's more. They are even bringing more and more and more innovation to the point of now looking, okay, when the patient is sick, what does he do? What can he do? Is it the right way to go immediately and seek a doctor at a hospital or at a USCF? Or is there an alternative way to avoid the patient maybe get out of home and contaminate other patients if he has virologic disease? Or is there other ways? And they are really looking at that. At that point, there are already some studies around, even as at CW1, we are helping the governments to change a little bit the way they think over this. And I will show one case immediately after. And this starts being discussed when it comes to the centralization. Then, of course, there's the case of Spain to keep improving the communication between the 17 regions. Nowadays, they already talk between them. They already work better. They have quite a strong digitalization within the hospitals, and things are moving at a fast pace in order to improve the way things are evolving in the system, and as well reduce the number of steps that the patient needs to do in order to access to proper care and quality care. Then, of course, we have as well the idea of the rotativity of medical staff, where doctors from the hospital suddenly they do clinic work within the USCFs or within the clinics, and they go back and forth between the both units without having to distinguish is a hospital doctor or is a GP doctor, general practitioner doctor, or is an internal medicine doctor. There's no more distinction except for surgeons, of course, and we have Maximilian here, who is a surgeon. Of course, a surgeon cannot go into the clinic because provide normal appointments, since surgeons are short in numbers and they need to be doing surgeries. But there's already a more thought of rotativity, which is quite cool. Then, of course, we have a push on digital transformation, and this is a huge push. There's an increased adoption of tech-powered diagnostic tools, which is quite cool because there are lots of medtechs showing both in Portugal and Spain. There's huge incentives from the governments to push these innovation forwards, and even EU is pushing this, which is quite cool because a lot of development is happening in this area, although it's not so much our area at CW1. Then, of course, there's the expansion of telemedicine and remote patient monitoring services, which is something that it's increasing day by day, which is quite interesting as well, because the patients start realizing that they don't have to be sometimes physically talking with their doctor, or they can do other things rather than going and booking an appointment, and that's quite interesting case. And there's as well the interoperability, the implementation of interoperability electronic healthcare records, which means that systems from both public units, and in Portugal, the SPMES, it's the entity that controls the hospital systems as well, the USCF systems, is already defining ways for the both systems to communicate, and they start to communicate, although still struggling. and I have many doctors that's in my network that they all say the same. They struggling to access to full record of the patient, but they are already unifying their records and having similar to the Nordics, and that's a huge milestone in the Portuguese system, to be honest. Then all the concept is being introduced and it's being very developed, which is the patient-centered care, where there's a huge focus on the patient and how does he experience the quality care? How does he move within the hospital? Is he guided? How many steps does he need in order to finish his journey as a patient? Many questions are being asked, looked at the same time on the economic side. How can it be improved? How can it be changed? How can the patient perceive better mobility? These are all questions that they are questioning themselves. And then, of course, we have the implementation of value-based healthcare models, where there are specific standards across different providers in order to everyone, in similarity like the Nordics, perform the things the same way. And that's something that is being pushed, although with some resistance on the more elderly doctors, but it's something coming up to speed, and hopefully by 2030 to be fully implemented. Then, of course, we have cross-border collaboration. There is so many public-private partnerships happening, which it's a change in Spain, and Portugal is, the new government is as well bringing more public or private partnerships. It's a change that it's happening, and it's becoming more and more common practice, which pushes the healthcare system, public and private, to talk between each other, which has been a huge problem between both of them. And then, of course, we have the participation in EU-wide healthcare initiatives and research projects, because that's where truly innovation and research happens and pushes other countries in the EU to adopt these changes and bring more. We have a case of how could it work, and it's something that it's being implemented and actually quite interesting to look at. In one side, we say that everybody moves in one side, and when we look at systems, they can be divided and worked in a different way and used for different purposes. And this is something that we use internally at CW1 for analyzing analytics and actually obtaining insights that we need to provide data for studies or data from partners that ask us this, and as well doing research over economic trends. But it can have so many potential that sometimes we ask ourselves, why don't we just open our ecosystem to everyone? But that's another story. I will not bother this in this webinar. Let's talk a little bit how it can look like. So we can divide the system in the physical part with the provision of care. And when we talk about provision of care, we talk about multiple things, multiple different things. And it's more aimed to the physical actions that the stakeholders take in each of their positions, not only patients, but doctors themselves as well. And on the other side, we have the analytics and the research diagnostic of how can the data improve the workflow of the patient within the hospital setting? How can the journeys be reduced? How can he at the same time experience more care and more quality care? And for that, we say that a privatized public EHR ecosystem would work. Needs to have many data compliance oversight, especially needs to be fully anonymized data in order to control that, even if there's a leakage of data or if there's any issue, there will not be ever at risk of citizens' data to be leaked out and be discovered by outside parties. And that's something that's compliance-wise, it's really important to look at, and it really needs many certifications on it. But that's another story. Let's go into the functionality, how the both parts work. So on the analytical side, all the data can give new models how to optimize the working functions of the hospital. And Maximilian, I know that our German listeners in this webinar are curious how this is working, but in Germany, telematics is already doing part of it, and Maximilian will explain it better. But for now, I will explain, in this case, more possibilities, more outside the spectrum. So if, as I was saying, we can obtain data to optimize the hospitals and create new models over how the workflows work. and how can they be shortened and optimized to drive cost reduction. We can bring cost innovative workflows. Sometimes there's no need for 8 steps. It can be done in 4 steps. It can be done in a different way. It can be looked at different vendors and different alternatives to increase the patient care and at the same time reduce the cost. And this is possible as well. It can drive performance. It can manage performance. It can say, okay, this physician has too many hours followed, or it works in a very active way, maybe needs more rest between the times it's free, or there's ways to drive performance in order to the patient feel, yes, this is quality care. And then, of course, there are the standardized pattern diagnostics. This it's not our area so much, but there's ways to bring as well to analyze the data and look how to improve diagnostics. We provide our partners with this so that they can use the ecosystem for the way they develop their devices and their data and their methods in order to develop their diagnostics. We are concerned really at looking at the workflows. Then, of course, on the physical sides, it has huge impact. Why? Because it speeds up and shortens the patient journey. That's the first step. The patient that feels it shorter, it's way better than feeling, oh, I'm still sick, oh, I need so much time to get well. It brings more digitalization and less overload to the professionals. It brings easy access to the rural patients because they can do everything towards their phone, which is quite nice. And then, of course, it becomes a response to the increasing of patients over 55 years old, because we have a joke in CW1, we call them the baby boomers, but we know that in 10 years there will be a problem with beds in the hospitals, and we need to solve this issue of the age pyramid where there's an excess of people over 55 years old that need care and attention, and we need to find new flows in order to provide mobility to them. Looking at the German reality, and I will let my colleague Max to explain how it's going to look like. I'm a little bit tired, so Max, you have the words to tell us how the German reality is going to change.
Thank you very much, Pedro. Yes, let's talk about the German reality due to the hospital reform started years before and now pushed by Professor Lauterbach. And the idea was do a cost reduction, improve the patient care, shorter the patient journeys, lower the bureaucracy, and get a better communications. All these are converted into ideas combined with the idea with the patient decentralization, that telematic and gematic got less monopole situation, and openness for more different medtech companies and medtech ideas in but respecting the new C5 certification, which is acting since the 1st of July of this year, and establish a better communication between the all the healthcare sectors. And also the hospitalized privatization got better contracts, and all these things, as mentioned previously, are converted into ideas to get as possible as best ideas and tested in the hospitals. And then now these are the ideas of the reform and written down in the contracts and try to improve but what is happening now in the clinics and how can be these things more and more improved. When we have look at the telematic infrastructure 2.0.
Oh, sorry, Max. Yes.
Yeah. When we have a look at the telematic infrastructure 2.0, there should be a better communication and with some kind of the electronic prescriptions. It tries to get a better prescription and communication between the healthcare providers. We at CW1 see where many potential to make it better and more efficient. And when one of the big problems today, still in the 21st decade, is the communication between the hospitals and the outpatient healthcare providers using letter or fax, because all other ways are be not secure or not be in the C5 certification, and there can be more and more better possibilities when the government opened this way and support these companies like CW1 to establish better communication ways. That would be a huge benefit for hospital doctors like me, because it would lower the bureaucracy and the daily admission work, being a doctor, not a secretary, and also give the insurance a better insight in the healthcare, that they can provide better options for people, for their insured people, like preventive medicine, healthcare training, all these things. And all these things are summed up into the telematic infrastructure 2.0. And the idea for the future times is that everybody, all healthcare providers, the specialist in this outpatient clinic, me as a hospital doctor, or the pharmacist, get a better overview of the patient records, and all healthcare providers can communicate digital and in a faster way, instead of using letters or fax, just communication in real time over electronic possibilities. And this would also be led to more digitalization in the hospitals, because many things happened in a written down form, that these papers will not last decades, but digital data will last decades and will give better understanding of the diseases in the patient records, because also the researching pharma industry, the medtech companies, all healthcare providers, not only working directly on the patient, need these data to improve the healthcare landscape in Europe and especially in Germany, because at the moment there's something lacking the most known German spirit of innovation, and this would be led in the end to use a group effect when all healthcare providers and also the patient all combine their threat. We would be in a better and the next generation of healthcare providing and using the new novel technologies, like, for example, from CW1, the MedUX or something else, would improve the healthcare landscape in Germany. So I would pass the word back to Pedro. He would sum up and would give the look over the EU in the end.
Okay, thank you, Max. Let's talk about what EU is going to do. And EU, there's always the concept of the European healthcare records and how it's going to work across the whole block. And many things need to be introduced. But EU is trying to focus in 4 different pillars, 4 different phases, in order to push this innovation forward as soon as possible. So they will look at the collaborative framework first and foremost, because it needs to collaborate between all the different countries. Otherwise, it just doesn't work. And everyone needs to talk with each other and say, yes, let's do the things together and actually push the things forward. They need to look, of course, at the commercial framework. There are a lot of stakeholders, from medical manufacturers, from hospitals, from general practices, from laboratories, from pharmacies, from psychologists, from everyone who touches health, from any possible patient, needs to actually be recompensated, and this brings over the commercial framework. Me and Max, we met each other as well And since the beginning, we have been talking about, for example, the Daedalus within the hospital systems of Germany, that it doesn't talk with other systems that needs to talk. And this is something that we need to push and change, and something that needs to be looked at. But of course, the commercial framework and the commercial interests put some blockage in order to talk and to move forward. Of course, there are other ways to do it, but it's a thing that the EU is looking at how to change and make everyone happy at the same time. It will focus as well on the patient, especially on the idea how to provide better care with less resources, because we need to cut in costs, we need to spend more money, but cut in costs and improve healthcare at the same time. It's one big concern of the EU. And then, of course, the regulatory framework, it's something very intense. It's going to become even more intense. Maybe some ISOs will not suffice anymore, as it was the case of the C5 in Germany, as Maximilian was mentioning. Suddenly the ISO 27001 or the ISO 9001 and the ISO 13485, they don't fit anymore. They need more security, more oversight. This is something that is going to even become harsher and harder, because needs to really, it's healthcare and needs to be properly done. And there will be even an increase in the regulatory. So when we look at collaborative framework, what will happen? There will be more innovation, not only central and local. There will be push of saying, okay, let's decentralize everything, but let's restrain as well every local unity in a more innovative way, in a more digital way, in a more technological way. There's a huge incentive to this. There will be more collaborations showing up between public and private. I know Italy is looking quite a lot into this. I know that Austria is looking into this as well. I know that Germany starts talking with this, although the whole tendering process, it's quite exhaustive. I know France has been looking into this for many years. The Nordics are looking into this, because it cannot be anymore only public, but there are other ways to actually cooperate between both entities. Everyone is looking into this, which is a good thing in the end. Then, of course, we have better control of healthcare costs. This is essential. We need to look at how much is the spending in order to improve the overall health provision, and as well increase the communication between different providers. Germany and the Nordics have huge economies. The South doesn't have. How can we come up with models that work for both parties and actually can make everyone talk and make everyone have the same healthcare provision and still be sustainable for all the parties involved, including insurance companies? This needs to be looked at. And then, of course, we have the improvement of standardized practices so that everyone does the things in the same way, so that the healthcare provision can be the same across any country out of the bloc. On the other side, we need to look at the commercial framework, and the first thing that the European Union is already looking is at different channel dynamics. Needs more players, needs more opportunity, needs more financing, needs more openness for other people to present their ideas and come forward in the market. Needs to balance the power with the providers. Cannot be anymore everything 90% to the big pharma or to the PE. Companies such as Siemens needs to actually have more openness in the whole market and let other providers to come in. Needs more innovative attitudes. It's not all about profit. Sometimes innovation needs to happen in order for everybody to have access to the same technology. And this is a very important step. Everyone needs to have access to the same technology, because we are not anymore in an era where technology was such a secret. There's internet, there's a lot of communication going 24 hours per day, and everybody has the right to have access to the same technology, and the information about it, it's public. It's mostly public. People talk, and it's already crossing the all countries and giving awareness to other countries. Hey, why in countries like Sweden there's things like Bank ID, but that doesn't exist in Germany, which would solve huge problems, or doesn't exist in Portugal, which would solve as well huge problems. People are talking, and times needs to change, and the EU is looking at this. We need better healthcare insurance software, because some healthcare in Germany, it's quite solid because the whole system was built in around that, but in other countries needs a better offer. Countries like the Nordics, it was always public, it will stay public and might not change, but needs in the south, especially Southeast Europe, needs to change and needs better insurance there so that it reduces the high costs with out-of-the-pocket expenses. Then, of course, needs better care when we look at the patient basis, needs better patient-centric care, needs to put more emphasis in the patient, needs to say, hey, yes, you have a role in your treatment. Yes, you have opportunities to choose different approaches. You have more power of decision. The doctor communicates easier with you. There are ways to actually be more involved and they reduce your journey as a patient. There are already policies being implemented where the patient has the decision. The doctors present him different solutions and he decides which approach he wants to follow. That's a better practice across all Europe. And it's being more and more explored how to improve this and how to bring it even more in order to increase the patient centricity. There's the concern of diminishing shorter patient journeys and bring more innovation into how the patient experience and moves towards his own journey. How can it be reduced in order, because no one likes to be sick, no one likes to have disease. How can we shorten this? How can we bring innovation to this? And the EU is really putting too much emphasis on this. And then, of course, in order to deal with the shortage of medical personnel and as well with patients who don't like the way the care is provided, they are trying to improve as well the doctor satisfaction with the care of. Sorry to all listeners, I'm already getting a little bit tired of speaking, but I will try to not give these mistakes. But how can we improve the way the doctor perceives as well his own work and be more satisfied with the way he provides medical treatment to his own patients and to improve the patient experience? That's something that the EU is looking quite a lot into it. Finally, we have the regulatory basis where the EU is looking at more standardized practices. How can we include all hospitals doing the same thing in the same way and yet still be compliant and still be regulated so that everyone does the things properly and there are not so many gray areas to operate? This is quite a huge concern. And then, of course, the IT security is being really improved in all countries of the European Union in order to be secure and to be quite strengthened and quite harsh in order, if someone decides to act in the gray area, it's a big no. Countries like Germany are already showing that. No more gray areas. There's the C5 and everybody needs to have it, which is quite cool. Everybody, which that touches patient patient data in the clouds. Some hospitals are exempt of this because they have their own internal systems, but usually in new medtechs, they are all touching the patient data in the clouds, and this needs to be really certified, and it's obligatory by law since the 1st of July. This drives a huge change, and in 2030, there will be quite a huge change implemented by then. But since we are not there yet, we will terminate here this presentation, this webinar, and hopefully you will like it. Me and Max, we have now some space to questions and answer. If anyone wants to ask us some questions, please feel free to write it here in the questions and answers in the chat of Teams. You need to access Teams in order to post your questions, but feel free to post questions, comments, whatever it is. Both me and Max, we are here to answer. Let's wait some minutes to see if someone comes forward. Okay, perfect. Then I wish everybody a good afternoon from this moment. I say goodbye here. Maximilian, I don't know if you want to say a few words before we say goodbye to our listeners.
Thank you very much for joining our first webinar of CW1, and I'm looking forward for our next webinar. I can just announce that in some days we will announce another webinar where Privatdozent Dr. Rene Burchardt and me are talking about the German-specific problems in the actual moment, and this webinar will be hosted in German for our German colleagues. So that's my last statement. Thank you, Pedro, for the invitation, and I would pass the word to you back.
Okay, I wish all a good thank you, Max, as well for taking the time. I know you have a quite busy agenda, and thank you for being here as well. So I wish everybody good afternoon and goodbye to everyone. Me and Max, we say goodbye and thank you for joining this webinar. Have a nice one. Bye-bye.
Bye.